Welcome to Queer Onda El Paso, episode 31, Living with HIV.
I've got something to live for, got a reason to want more, ain't going down.
In the early years of the HIV epidemic, particularly in the 1980s, an HIV diagnosis was often considered a death sentence. Without effective treatments, it was a terrifying, stigmatized, and rapidly fatal prognosis. Today, it is managed as a chronic, treatable condition. Still, there are many misconceptions about HIV treatment, and many patients still struggle with the perception of the stigma attached to their diagnosis. Our guest today is Dr. Ogachika Alozi, who specializes in HIV care at Sunset West Health. He combines a positive bedside manner, his knowledge and education of infectious diseases, and the use of cutting-edge technology to his practice. Doctor, welcome to Queer Onda El Paso.
Thank you very much. I appreciate it.
Before we begin to talk about HIV treatment and diagnosis, tell us a little bit about how you came to practice here in the Sun City.
I have an interesting journey. I'm not going to belabor you with the long story, but so the short form is born in Nigeria. Grew up in Minnesota. My parents were a typical Nigerian immigrant story. My dad was a PhD. My mom was a mom, was in Minnesota for a very long time. Unfortunately, my dad died young, so it was just me and my mom. At a point in time in my teenage years, I think every teenager goes through some certain angst around being in a community that they don't feel necessarily welcome in, right? So I grew up in Roseville, Minnesota, one of only 4 Black kids in my high school population of 1,200. And at some point in time, I was going down the wrong path. So my mom sent me back to Nigeria. So when I was a junior in high school, she actually sent me back to a boarding school in Nigeria where I went. That's a whole different story.
Oh my gosh. I want to publish a book.
I mean, I feel like I'm going to write it.
Yeah, I know. That is amazing.
You think about taking any American 16-year-old, right? I was the typical 1980s 16-year-old on my bike, jumping on trains, shoplifting from time to time. But the point was that she didn't want me to go that direction. So she sent me back to Nigeria, went to boarding school there, went to med school as well. But when I was done with med school, and it was in med school in a city called Benin in Nigeria that I got my first introduction to HIV. And at that point in time, as we all know, there was no cure. Right? We're talking about there's no cure, there's no treatment in the United States.
Doctor, just in context, what year is this?
This would have been 1991 to 1998.
I see.
But I was in medical school in Nigeria. And so we had HIV wards, which were essentially, I won't call them graveyards, but they were essentially dumping grounds where families would take a loved one and leave them and nobody would ever come and see them again.
Oh.
And so that was my first introduction to HIV. And at that point in time, I didn't want to have anything to do with it. But I was like, this is scary, this is terrible, and this is just not what I want to be a part of. After I finished training, worked a little bit, and then came back to the States. So I came back to the States in 2002, did a master's in public health and infectious disease epidemiology, did my residency, and somewhere between my master's and my internal medicine resident at a hospital called Hennepin County Medical Center, my mom's sister actually contracted HIV in Nigeria. And the process of having those conversations with her just sort of lit a fire in me. And I started being really interested about, this is wild that my mom, who is a PhD holder as well, was afraid of her sister, right? Was worried about, can I use the same silverware with her? Right. Can I use the same bed sheets and all that stuff? And like trying to calm her and allay her
Which was,
fears.
In complete defense of your mother, which is the common knowledge or the perceived knowledge at the time. I mean, there are people that so very much, it's hard for somebody today to understand what fear people felt around
Oh,
HIV.
Yeah, it was terror. And she did her best. It was her sister. She loved her sister. But even then, walking her through that process was just something in me. And I think PEPFAR was just coming online around then. So I just started becoming really interested in it. And so when I had to make a decision on what I wanted to do to specialize off of internal medicine, infectious disease was what, for me, just sort of lit my fire. And so I did my infectious disease fellowship at the University of Minnesota. I worked with an amazing man, Keith Henry. Actually, he will be attending his last CROI this year in Denver. He's been to every CROI that's existed, but he's finally retiring. And so he trained me. And so he was huge in that space. He sat on the ACTG, which is the AIDS Clinical Trial Group, has hundreds of papers, started a clinic in Minneapolis, which is what I modeled my clinic on, and we can talk about that later, called the Positive Care Clinic. that lived inside of Hennepin County Medical Center. And a lot of the things that we do here now, I learned from him in the early 2000s, it's 2005 to 2010. When I was finishing fellowship, in my mind, I was going to be in Minnesota. And I was going to be in Minnesota. I was a Minnesota kid. I was sort of reverse Oreo, right? I was partially Nigerian, a lot Minnesotans. That double, they call it the double stuff Oreos. Yeah,
it wasn't just extra white on the inside.
Yeah, I was super extra white on the inside. And so that was my plan. But as they say, man proposes, God disposes. And in this case, God was my wife. She hated Minnesota because it was too cold. And she had grown up in Minnesota, done all her training, lived all her life in Minnesota. She only came to the States because we had gotten engaged and then afterwards married. And so she said, hey, we got to go somewhere warm. She had seasonal affective disorder. And it was just, I always laughed that my kids were born in June and August. I don't know how we had kids when she had seasonal affective disorder in the winter, but that's neither here nor there.
It didn't help with depression.
Exactly. Endorphins, right? Endorphins. And so as we were looking around, I always thought, Baltimore, Atlanta, Florida, that's where I was going to go. Anywhere sort of below the Mason-Dixon line was how I sort of had it in my head. And one day I got a call from a recruiter and he said, hey, are you still looking for a job? I was like, I actually am. And I came to this country on a visa because I wasn't born here. So I started on an F1 visa, switched to what's called a J1 visa. And you may or may not know about the immigration system in America, as broken or unbroken as it is. But the J requires you to either go to your home country for 2 years or stay in the States for a minimum of 3 and then convert to what's called an H-1B and a green card. Too much immigration legal mumbo jumbo.
Right.
Long and short, Texas Tech here in El Paso had 2 ID physicians, but they didn't have an HIV physician. And they were interested in starting an HIV clinic. And so they said, hey, do you want to come? You'll get to start your own HIV clinic. No bureaucracy, lies, but that's neither here nor there.
Yeah.
And
they were sweetening.
Yeah, you know how it is. They always sweeten the pot. It's for you. But so that's why we moved to El Paso in 2002. And then my career started there.
Specifically focusing on your HIV clinic.
Absolutely.
So tell us then at that time, tell us about what year that was and where HIV treatment was in the process to getting to where we know it today.
Absolutely. So in 2010, which is when I moved to El Paso, the standard of care for HIV treatment was protease inhibitors. So things like Kaletra and Rayataz and Prezista, right? These are all boosted molecules. So you had to take one type of medication plus a booster that was usually called ritonavir. They had started to couple them together in Kaletra, which was 2 tablets twice a day. It later became 4 tablets once a day. But it was always multi-drug regimens, right? Multiple tablets, hopefully once a day, more than once a day on average. And that's what we're trying to do, getting people on them. I remember then the biggest thing is that we had what I call the PI cocktail, right? Somebody would come in and the first thing I would tell them after we sort of talked about when are you going to die? You're not going to die if you take the medication. How can I transmit? You got to take your medication. Got to use a condom. It was then, you're going to have nausea and vomiting. You're going to have diarrhea. And this is a bag of medications that's going to help you through that. Either Zofran for the nausea and vomiting, Imodium for the diarrhea. But usually in 4 to 6 weeks, you will get through it and you'll be fine, right? That was kind of the contract, social contract, medical contract that we would sign with patients to give them that expectation. And we grew really quickly, right? LaFay was already here, and LaFay is a great organization, but I think people should always have choices, right? It shouldn't only be one place that somebody needs to go. And so we offered an alternative that was an academic health center. Because we had other specialists around, I could get them into cardiology, GI, nephrology, primary care if need be. And so we grew rapidly from our sort of quota of 25 patients to I think well over 200 patients in the 4 years that I did that with Texas Tech.
That's exponential growth.
Yeah, it was amazing, actually. And so in 2014, it wasn't necessarily I didn't enjoy working at Texas Tech, But if you ask any of my friends, my kids, my wife, they'll tell you he's way too impatient to be in a bureaucracy.
And I was going to say that system has a large bureaucracy.
Yeah, and it's an academic health center bureaucracy. It's not a bad thing. They have safeguards and guardrails around things, but I'm not wired like that, right? I wanted to do things faster. I wanted to open a pharmacy. I wanted to make sure that when our clients came to clinic, their medication was waiting for them and they didn't have to go off to a different pharmacy. And those are all the tenets that I learned from Dr. Henry in Minnesota. And there were just too many things. Oh, we can't do this. We don't have a pharmacy. We got to partner with University Medical Center in El Paso. And UMC was a great partner. Don't get me wrong, right? They actually were willing to give me a pharmacy partner. I truly believe that if you're doing HIV care, you need to have a pharmacy partner because a lot of drug-drug interactions, getting people on Ryan White, getting things approved, insurance, non-insurance, all that stuff. And they were helpful with that. But again, I just felt I could do it better and faster. So in 2015, I made an agreement with Dr. Richard Lang at that point in time. And I said, hey, I think I need to take this outside the university. There's nobody else that wanted to do HIV there. And so it was an easy win. You can't see it because it's not on video, but outside my window, there's a primary care clinic. And that's where we started. Suite 1A and 1B, and we partnered with Project Champs, who's still our partner now, and sort of went from there.
Wow. So now at that point, when you started, is it your practice here as kind of an offshoot from this HIV clinic and kind of like was incubated at Texas Tech. And so you went out on your own and you've expanded your practice ever since. So tell us a little bit about where treatment is right now for HIV patients. I mean, from diagnosis to ongoing care.
So the way it is now is, wow, I won't call it quantum leaps, but I didn't grow through it, obviously, but in the 90s even, the way therapeutics then, multiple pills, multiple times a day, a lot of side effects. People would get gallstones and pancreatitis and hepatitis, and some people would get yellow eyes from the medications. Funny story, some of the patients actually enjoy it, right? I would have patients that would say, hey, don't take me off that medication that gave me these yellow eyes because the only cool thing in my dating scene. It's the only thing that makes me relevant, right? But in 2026, the standard of care is one tablet a day, and the standard of care is what's called an integrase inhibitor-based regimen, right? And so I think 90+% of our clients that walk in are getting one pill a day. And within 6 to 8 weeks, if they're taking it without any background resistance that we can talk about, they're getting to undetectable. Once upon a time, you never said somebody would get undetectable in 4 weeks. It was 3 months minimum, right? And actually, you check their viral load after 3 months to see if they had what was called a 2-log drop. So you just take 2 zeros off any number. And if they remove 2 zeros in that 90 days, you said they're on the right track. Now, if I get to 90 days and you're not undetectable, we need to have a conversation about, are you taking the medication? Are you taking the medication? And are you taking the medication?
Yes.
It's rarely resistance these days in somebody that has a new HIV infection.
So the medication is that effective.
It's amazingly effective.
Without a doubt, you can actually tell if the patient's taking it.
Oh, absolutely.
It shows in their viral load.
Absolutely. I mean, it's changed the paradigm around HIV to being, we're managing this to keep you alive for a few years before you decline, to we can keep you alive, but there's a lot of side effects and a lot of other things, and your life expectancy isn't the same, to, oh, wow, not only is this keeping you alive, we're no longer talking about that. Now we're talking about normal life expectancy. My clients and patients that, may their souls rest in peace, have passed really in the last 5 years from heart attacks and cancer and other things like that.
Doctor, I had shared with you that Izzy, my co-host, worked at the Southwest AIDS Committee in the early days of the pandemic. We're talking about of the AIDS pandemic, I should say.
In the 90s.
In the 90s and early 90s, actually.
Yeah, yes.
And there was very little treatment available. There was more just kind of dealing with the diagnosis and palliative care, because it was just assumed that they were only going to be here, whatever patient, for a short period of time.
We actually had an end-stage clinic.
Yeah.
Where they came and lived there until it was over.
Passed.
Do you still have patients that are afraid of being tested because they have that memory of what HIV/AIDS could do?
Honestly, I'd say no. I will say this, however. my clinic population skews young.
I see.
So the average age of diagnosis these days in my clinic is anywhere between 17 and 25. These are
young.
kids, as I call them, that have no recollection of idea of what AIDS was in the 80s and 90s. I then have sort of what I call my little camel bump on the back end, which are my above 60s, right? They are aware, they know, but they're not afraid of testing because they've been through this for the last 30 years, right? And so testing isn't necessarily their issue. They come in and sometimes when we have time and talk about things, they're just amazed at where they are today in 2026 and where they were in 1986 or 96 or some of them 2006. Where I do see the questions and concerns about testing rear its head is in the MSM, gay, whatever alphabet soup community you want to call it today, right? And again,
And it is a big alphabet.
I don't say that in a pejorative manner, but I'll have 10 clients come in and 10 of them will speak about what they want to be named or called 10 different ways, right? So I just tell them, what's your name?
Right.
Right. And again, not to make this political, I've gotten away from the he, she, we isms and just say, hey, my name's Oge, or it can be Dr. Lozzi. What do you want me to call you?
Right.
Right. Is it John or Jennifer? Is it Peter, Paul, or Mary?
Well, I wish everybody would simplify it like that because it does make everything so much easier, doesn't it?
It makes things so much easier.
And it establishes trust with the patient almost immediately. It would seem.
Absolutely. And I tell people all the time, too, and my staff used to laugh about this when they were new. When I have new clients, I tell them, hey, this is just like dating. Whether you want to swipe right or swipe left is up to you. And I'm okay, and I will not take it personally. But if we swipe, I think it's right, on this physician-patient relationship, then I'm going to bring my best to the table.
Right.
I need you to bring your best to the table. Understanding, I know you're going to fail at some point in time because to fail is human, and I'm going to screw up sometimes. I may forget to send a prescription, right? I may be out of town. Mm-hmm. My team may forget something. We're not doing it deliberately. It's never an intentional effort to fail you in your healthcare. But just like you're human and you didn't pick it up from Walgreens or CVS, or you traveled and give us an address change, we sometimes forget things because we're overwhelmed that we also have families, right? But on average, just like dating or marriage or any relationship, you hope, I use Pareto principle a lot. You hope that you get to that 80%, right, and we can figure out the remaining 20.
Right. And it's got to be reciprocal. You've got to have a willing patient and a willing medical team. So in your experience then, now we're talking about your younger patients, which is the majority of your practice. Yeah. When they, you all offer free or HIV testing, is that right? And then you can deal with whatever results may come at that point.
Absolutely. So one interesting thing, I'll just sort of call it out, is that, as I said, in 2015, we started as an HIV-only clinic, right? We quickly realized that our patients were coming with their family members. Sometimes they were also HIV positive. Sometimes they were a mom or an aunt, cousin, brother, or friend, and they were not HIV positive. And they enjoyed the environment of the clinic, and they would say, hey, can you take care of me? Mm. So we started doing primary care for family members and friends of our patients. Oh, right? So that's how we sort of took primary care. Then hepatitis C exploded right around 2012 to 2018. And when I say exploded, the epidemic of hepatitis C didn't change. The treatments changed.
I see.
So it went from a very bad treatment that was injections and pills and was a flip of the coin whether it worked, to pills that were essentially 12 weeks and had a 90% success rate. So we started having a lot of patients that were either co-infected with HIV, hepatitis C, or mono-infected with hepatitis C only. And the difference is that I can cure hepatitis C most of the time. Then they would come in. And then as my journey sort of evolved through health information technology to being at Del Sol as a CMO, and the COVID pandemic came, and I came out of that really more galvanized, realizing that, again, I was kind of a pain in the butt to anybody that wanted to be my employer. And I didn't have the patience. And so I just said, you know what? I know what I do really well. I think I give really good patient care. I think I can build a team that's energized and wants to care for clients and patients when they come in we're just going to go back to it. The unfortunate thing, and this is the business side of everything, right? There's no mission without money. And so to sometimes keep the lights on, apart from Ryan White, I need volume. And that's why I started doing general ID in the hospital, right? So I sort of think of us now, we are a full service infectious disease organization. We'll take care of your HIV, hepatitis C, primary care, hospital concerns, and we're actually evolving into infusion and wound care. So if you have any type of infection, and I see you here on the street, at Walmart, Whole Foods, on TV, or at a hospital, we'll take care of the full spectrum of it to take care of you, right? And so, but at the foundation, we are an HIV clinic.
Well, that's extremely reassuring for any of your patients, I would assume, because one of the things that anybody that's kind of navigated the current medical system that we have, either as a caregiver or as a patient, is that you kind of are outsourced to a many number of different offices, and there's a lot of inconsistencies in communication. And so that's got to be reassuring in itself. Let's talk about the emotional and psychological place that your patients find themselves when they learn of their HIV diagnosis. Can you speak a little bit? I know it's difficult to generalize, but for the most part, in your experience, doctor, what are some of the more emotional reactions? And then that leads to the practical, like, what are we going to do about it? But what is it that pause when they learn of their diagnosis?
I'll break it into two generations, actually. So when I first came to El Paso, the word I would use was fear. Shock and fear. I mean, we all talk about DAGBA, right? Those stages of grief: denial, anger, grief, bargaining, acceptance.
Yes.
There was a lot of denial, anger, and grief. It was the DAG part of it. Mm-hmm. That was what would walk into clinic the first time. And so my approach to it was always, you have every right to be angry. You have every right to be scared. And the number one question I would get in majority of my clinics is, when am I going to die? Not if I'm going to die, but when. And so the first thing I would have to do is reassurance, right? If you take this medication, and if we find the right medication for you, the chances that you're going to die are very low, right? I think that was my sort of foundational element with everybody that walked into our clinic. Thereafter, it was the fear as well of, how am I going to afford these medications? How do I even begin to get them? Where are these medications? I heard they're $10,000 a month. Thankfully, the Ryan White program, and we don't have to go into the history of Ryan White, but the Ryan White program provides that bridge for individuals that don't have financial means to get on therapy. And you know what's remarkable about the Ryan White program? I take a lot of tangents, is that if you compare Ryan White to Medicare, to Medicaid, to commercial insurers, Ryan White outcompetes all of them in outcomes over the last generation. If you are on Ryan White because of the case management and because of the HOPWA and because of not having to worry about a lot of other things, your care is better.
Interesting. Right? And reassuring.
Reassuring. In 2022 to 2026, I can honestly tell you, if they're under 30, there's no more fear.
Huh, good.
And it's not, I don't necessarily think it's because they're not still scared, but the internet is a powerful thing. And these devices we have in our hands, I almost have nobody that walks in here under the age of 30 that hasn't researched the hell out of what the plan is, right? So when I offer them medications, most of the time they're like, yeah, I saw that. Or they watch the Super Bowl commercial. It's that mainstream now in America that you watch any late night TV or any sporting event, you're going to hear about something that's an HIV treatment pill, right? Or you're going to hear about a prevention pill, right? So the new generation of clients, they're not afraid per se. They want to optimize their care. What am I taking? How often do I have to take it? Do I have to take this pill forever? When can I get a cure? Is there a shot I can take? Is there an infusion I can take? What about that every 6 month thing that I heard about during the Super Bowl, right? So it's a very different emotional set.
Right. And certainly there's a lot more education available, as you had mentioned, of course, much more so than when Izzy and I were working the early stages of the pandemic.
Absolutely.
So that seems to be extremely reassuring. And even though it doesn't seem like it's a long time ago. The early 90s was really a long time ago. I mean,
Yes,
we're talking
it
about
was.
36 years ago. So
Absolutely.
in that 36-year arc to get from where we started to where we are today is certainly reassuring. What about young people that come in and they you do HIV testing here and you test for other sexually transmitted diseases?
Absolutely.
Assuming whether they're positive, they go on one track for their care. If they're negative, do you offer PrEP? Do you offer any other kind of recommendations in terms of staying disease-free yet sexually active?
Absolutely. So I think, first of all, everybody should realize is that sex is great, right? There's no...
You'll get no argument from this.
Well, and it's so important for human development
Absolutely.
and for human connection and things
Absolutely.
like that. So we need to stop stigmatizing it as
Absolutely.
a terrible thing.
And so one of the other things that I believe we are is a sexual health clinic, right? We are encouraging people to be sexually healthy. And that goes with the testing. So if you come in and test and you're positive for anything, whether it's a virus or a bacteria, we will work with you to get it cured if it's possible to cure it, get it managed if it's HIV. And when we've done all of that, there should still be conversations about prevention and health, sexual health. And that's where the whole conversation about PrEP comes into play, right? And not just PrEP these days, it's now doxy PrEP, right? Reducing the risk of chlamydia and gonorrhea, as well as reducing the risk of HIV.
So doxyprep can do that.
Yes.
Interesting.
The doxycycline side reduces the risk of contracting gonorrhea and chlamydia, while the PrEP, or the pre-exposure prophylaxis piece, reduces the risk of contracting HIV,
I see.
right? And so different clients have different things they're focused on. Again, one of the things about PrEP is it does a great job of reducing your ability to get HIV through unprotected sex, right? And that's fair. But what people forget is that, yeah, you're protected against HIV. You can still get chlamydia, gonorrhea, syphilis, herpes, and a bunch of other things that are out there. And so when people ask me, well, do I have to wear a condom? I said, it depends on what your risk is. And not your risk, because your risk is your risk. It depends on what you're worried about. Right? If you are telling me that I don't want to ever contract anything, you got to wear a condom. Right? That's the bottom line. It's the best protection you have against all the other stuff. If you're saying that I'm in a relatively monogamous-y relationship,
Ish.
again, we can argue about those terms and how nothing's 100%, right? So again, 80%-ish. If you're in that kind of relationship, but you might still be at risk, right? PrEP is great if that's your concern. Doxy PrEP is great to take care of some of the other stuff, understanding that doxy PrEP doesn't take care of syphilis or warts, right? HPV is still real. HSV, right, is also real. Herpes. And so again, it all depends. I try not to make a blanket conversation to anybody walking in here about what we're going to offer. But if they tell us what they're afraid of or what they're worried about or what their sexual activities are, we can put together a package for he, she, or we, depending on what their needs are.
Well, so it really is individualized to the patient, their lifestyle, their concerns. And you brought up HPV. You offer HPV vaccinations?
We do. We try to vaccinate against any and everything that's out there if we can get our hands on the vaccine.
And again, the younger generation. I remember in another client, I do work for the Rio Grande Cancer Foundation, and there was a lot of resistance in particularly, I mean, again, avoiding as much as possible blanket statements, but the Latino community and young women and the necessity for them to get the HPV vaccination and the resistance that people say, well, we don't want to see, we don't want to consider our child to be a sexually active, which is in complete contradiction to the fact that there are, teenage mothers every day. There are all these other diseases that are being contracted that can be avoided. But when it comes to the HPV vaccination, that is a serious vaccination that could protect from an incredible medical event. Talk a little bit about that.
I'll tell you this. So yes, and yes to all the things that you said about protection. It is remarkable. It's no longer theoretical. So the data is really clear about that now, that HPV vaccines have already cut the incidence of cervical cancer. I think that has to be called out across the board. And there's some data that it's beginning to change the incidence of rectal cancer, right? Because HPV is also involved in that. And so it always used to make me laugh when people say, well, I don't want my kid to be sexually active. First of all, they're sexually active.
Whether you want
Secondly,
them to or not.
even if they're the Virgin Mary, guess what? At some point in time, if they become sexually active, you're protecting them against future baggage, not today's baggage.
Right.
Because they could be 42 and have their first and only child, unfortunately have sex with a male that has HPV. They doesn't even know about it because he's not showing any signs or symptoms, and he has no lesions, get a bad 16, 18, 21, 25, the different types of HPV that could then lead to cervical cancer that could have just been prevented by a vaccine in their teenage years. They would have dropped their risk by almost 80%, right? And so those are the conversations. Texas Tech and the Vaccine Coalition and Immunize El Paso locally, they've done an amazing job of getting that vaccine out and getting that education. Once upon a time, El Paso lagged behind. But now if you look at all vaccines across the board in Texas, if El Paso is not number one, they're in the top 3 of any vaccine. And so that goes to the community outreach conversations like this, and the individuals in this community that do tireless work on education and public health and all those things and getting it out there. And so if there's one thing I would tell people, minus testing and treatment and prevention around HIV rather, is that if you have kids that are within that space, get them vaccinated. My kids have been vaccinated. I encourage everybody to get their kids vaccinated. You're not doing it for them today. You're doing it for them as adults.
Right. So now speaking about the younger generation, when you had mentioned that a majority of your practice are young people, what we would all consider, certainly the 3 of us sitting in this room,
The youths.
young people, the youths.
I mean, I call them my kids. I'm like,
Your
hey, how
kids.
many kids do I got coming in?
So talk a little bit about that. How the El Paso culture, do people come with their parents? Do they come on their own? The answers are probably yes and yes again, but also have you talk a little bit about how it is that a patient might darken your door and say, I want to get tested, I want to find out more. What is it that we can do, and how do they come?
Yeah, and more importantly, how do you reach or do outreach to young people so that they know to come to
Right.
you?
It's interesting. I laugh because I trained in Minnesota, right? Minnesota is 80-ish% Caucasian. I was one of the few Black people in my program, and a great learning experience, but it was very typically Midwestern. And individuals that came in that were Midwestern came in on their own, right? And the only time I ever saw patients or clients coming in with family members was when they were African immigrants that were coming with HIV. And so I was like, I moved to El Paso, and it was remarkable to me. Almost everybody came with their mother or their aunt or a sister, and it was usually the female side of the family. Very rarely was it ever a brother, uncle, or a father. In fact, I never saw a father.
Not surprising.
I can almost say categorically, I never saw a father. And so it was always like, wow, this 28-year-old is coming in with his mom, and his mom's doing all the talking. This is amazing. Pros and cons to that, because a lot of them, unfortunately, culturally, were very religious, were very sexually stigmatized. And I actually lost some patients, unfortunately, because their mother would say, you're not taking this medication because we can pray this through.
Okay.
Right? So that's sad. But it was reality. Fast forward to this last 5 years, I rarely see that anymore. Does it happen? Absolutely. But before it was the rule, now it's really the exception. I get kids, patients, clients coming in under the age of 30, they come in on their own.
Right.
In fact, if their parents come, they leave them in the waiting room now. Nobody's in the room with them unless they absolutely have to. I had a client come in last year with his mom and dad. And when they were done, he said, hey, can I touch you real quick? We were walking out. I said, can I touch you real quick? And he closed the door and said, do they have to come with me next time? I was like, you're 22. I think it's 23. You're 22, dude. You can do whatever you want. He's like, I'm going to tell them that you said they can't come. I said, listen, my relationship is with you. they're ancillary to this conversation. I think it's important for them to understand what's going on. But if you want to be just you and I, absolutely, that's no problem. And so that's how I approach it. If you want to bring a family member, I think that's great. Community support is important to help you get through that social stigma and the family stigma and some of that shame. But these days, most people are coming in by themselves and they're ready with information. They want to talk it through.
That's good. And that's certainly what we want to encourage. I mean, because let's face it, I mean, you're talking to two lifelong El Pasoans, two Latinos that grew up in the stereotypical Mexican-American household. And so...
And the mother is really important to that household.
But it can also be an impediment to treatment. And there's judgment attached and all these other things. And so it would seem like it would be much more liberating for the patient to just have a... strictly their own relationship with their physician.
And so I am willing, I'm bi in that sense, right? I am more than willing, not willing. I encourage my patients to say, hey, I have a family member that's interested in my care and my well-being, and they want to sit in with me. And it'll help me when I leave here cope and understand this. I have others that are like, get them the hell out of here. And I am too afraid to tell them, I'm going to need you in your system to encourage them to wait in the waiting room, right? And we'll go whichever way is most comfortable, because the primary issue here is, what do you as my client need to get you to the next step? Mm-hmm. If it's family, let's do it. If it's soloness, let's do it. But whatever they need, I can work with them to get there. And I think that, sorry, but one of the things that I tell the team, I think everybody that's here now, and we've gone through staff members over the years, is if you're going to work in this space, you got to be flexible and you got to be kind, right? You can't do anything else without it. There's some days I'm going to be here early. I come in at 7:30 and clinic starts at 8. But sometimes I come in at 10:30 because I was late in the hospital. Think about the same grace you give me for not coming on time, the same grace we give patients. Now, would I prefer a patient not to come an hour late and not call us? Yeah, it kind of sucks for everybody, right? And it's actually not about me. What I tell the team is that why this is so important to me is because somebody else has a time slot that they're now impinging on.
Right.
If you have a 9 o'clock, I've always dedicated myself to say, your 9 o'clock is your 9 o'clock. I'm going to try not to double book you as much as possible. So that means that you got to come on time, because guess what? There's a 9:15 or a 9:30. And to respect them, then you should come on time so we can take care of that. And so I think that all goes together in working through that mutual respect that you mentioned, right? That co-process of managing a chronic disease condition. I think that's really important across the board.
What about language barrier? Are there Spanish speakers on your staff, or has somebody come in that is primarily a Spanish speaker? Are you all able to accommodate?
So I am the only non-fluent person in the building.
But you understand.
Mi español es más o menos, pero entiendo muy bien, but speaking is not my forte.
Right. I mean, it's only because that might be talk about an impediment to seeking care. You know, if somebody were listening
it should never be an impediment. And here's the other reason why. It's not just me that provides the care. Right. I have 2 nurse practitioners that are here. I'm American Academy of HIV Medicine certified. They're American Academy of HIV Medicine certified. We have the only clinical pharmacist in all of El Paso that's American Academy of HIV Pharmacy certified, right? So I truly do believe that we give the best care in the city. I know there are other places to go, and people may need to go to a private practice, smaller clinic, larger organization, FQHC, and that's great. Sometimes we call them, sometimes they call us, but language should never be an impediment to their care, and it's not an impediment to their care here.
Doctor, just to kind of start to wrap things up a little bit, where do you see the future of infectious disease care? I read an article that you embrace artificial intelligence, and as much as it can help ease some of the work burden that you and your staff have to deal with. So talk a little bit about what you envision the future of care to be. I mean, the future is here now. This particular practice,
quickly
you all are actually embracing what would seem to be a new model of care. And so, and also embrace artificial intelligence. So can you talk a little bit about what your vision for your practice is for the years to come?
So I think of our practice as a multi-touch, full-spectrum infectious disease practice, right? So, and technology specifically, when you register, we'll send you a link if you want to be on the patient portal. And that patient portal allows you to see your appointments, your medications, and your notes, right? And so that's great. Some people love it. Some people aren't as tech savvy, and that's fine. When you come in, we'll help you fill out the paper. We have iPads out there. In every room, there's a little screen where while you're waiting, you can tap a few things and learn if you feel like you want to learn. Besides that, what we're moving to now is what I call ambient scribing. So you guys are here. In front of me is my laptop, and I take my laptop in. Sometimes I take nothing in, and I'll just do it from memory when I come back here. But it's still extra typing. I've had bilateral carpal tunnel surgery, and so typing kind of sucks. That's why I don't write, because my writing's terrible. And so we're using technology that I can just put my phone or a laptop down. It'll listen to all sides of the conversation, and it creates a note. Right? You may say, what's the big deal? Well, what's the big deal is that I then don't have to be typing on a computer.
Yeah.
I can make eye contact.
Right.
I can make physical contact more than just once or twice or 3 times, right? It enhances the engagement. If we can just have a conversation and the AI takes it and turns it into a clinical note, that's great. Embedded in the system that we use is some AI tools now that if we put in a diagnosis, it knows that I've written 5 to 10,000 HIV or syphilis or bone infection notes, and it tees up the orders already, right? So I'm not having to think, oh, what's that medication again? It knows that for the last 500 patients that I saw that were living with HIV, I used Dovato or I used Biktarvy. So when I click plus, which is the order button, they're at the top. And it already knows that when you see a patient the first time, these are the 18 labs. Oh, but this is a follow-up appointment. I'm only going to surface 4 labs in your electronic medical record. As we go forward in AI, and this is not on the clinical side, but on the research side, because we're actually involved in about 12 to 15 different clinical trials across the spectrum. Some of them are prevention, some of them are treatment, monoclonal antibodies, a whole bunch of stuff. AI is now helping some of those pharmaceutical companies create and develop molecules that will hopefully fast track how they can get to a point in time. Because the actual holy grail here is the cure, right? It's either a vaccine cure or it's a cure, a therapeutic cure that can actually get rid of HIV for the body or put it into a state of senescence with a few treatments so it never comes back. That's really the holy grail. And I think AI is on that side helping scientists. For us, it's helping us practice better, helping us practice safer, and helping us practice more efficiently so that we get the best out of the care we're giving, right? And the patient gets the best out of the care they're receiving.
And consistency in the way that you're treating your patients.
Oh, absolutely. So one of the other things that we've done for a long time, and it's part of my background as a chief medical informatics officer, is we've always looked at our data. Right. And so I presented at the state level that HIV organizations should be data focused and data centered and data forward. Right. You can't know the mistakes you're making if you can't even see it. Right. So we have tools. One of them is called Forward Health Group. So we have a dashboard. If you come around the corner, it actually shows where we are in terms of the HIV cascade. What percentage of patients that were diagnosed actually stayed or got seen in 90 days? What percentage stayed in a year? What percentage got antiretroviral therapy medications? And what percentage were undetectable after a year? And so historically, we've been in the 85 to 92% range, which puts us in the top 5% of the state. So we're really proud about that. But I think for us, technology is so important because it doesn't just enhance the patient experience and the clinician experience. It allows us to see data to help us better ourselves going forward.
Excellent.
That's
So-
super impressive.
Doctor, and so I'm assuming that Sunset West Health
Yes.
is open to all applicants that
Absolutely.
are interested in seeking medical attention.
Absolutely.
And perhaps how does a patient decide whether that they want to get HIV tested or if they want to get other types of sexually transmitted disease testing? What do you do? What does a patient do?
They can walk in. We have walk-in testing, so
Okay.
they can walk in. We do outreach to answer one of the questions that you had that I didn't answer before. We do outreach to the health department. They're one of our largest partners. And actually, in terms of testing, the health department and the hospitals are our biggest new patient sources because they're doing the testing and the outreach that we don't have the funding to do.
Right.
And then they're channeling patients to us for
I
care,
see.
right? I think that's important. We partner with UTEP to just let them know. And the community colleges, we actually have funding for 2 navigators that go out in the community. They do AIDS Ribbon Day, the AIDS Walk, the runs, all the things, and put our name out there. So letting people know, if you have an issue, come see us. And it doesn't, if you want to book an appointment, call, we'll figure that out. If you want to go online, go online. We have a website, sunsetwesthealth.org, actually, right? And you can book an appointment or ask questions there. We have an Instagram for people that are on Instagram. I think we have a Facebook. I can't remember what they do anymore. But there's so many channels that they can access us. I mean, the phone number is 915-229-6448 if they just cold call. But a lot of times we have people that walk in every week and they just get tested and hopefully they're negative. But if they're positive, then we figure it out.
Excellent. Well, I think Izzy and I can both agree that this is certainly a very welcoming environment.
Appreciate
and
that.
So most patients are going to feel right at home and feel cared for.
And your expertise and how you delve into technologies and stuff like that is so impressive.
I appreciate that.
No,
see, at the end of the day, I'm a nerd at heart, right? I'm a kid that was a nerd at heart, and my mom sent me to Nigeria to kick my butt a little bit, mold me into shape, right? And then I think I grew into an adult there and then got my training here. So hopefully I'm best of both worlds in a sense. My Oreo is a little bit more brown now because of leche and dulce that I get here, right? And the Toriados that I eat religiously. But I think, what I want people to take out of this is there still stigma? Absolutely. Are we working and trying to find ways to reduce that stigma? I would hope so. I think that any life that we can touch or change or give hope is a day in my life that is well served. And one thing that people don't realize, and my colleagues as clinicians and physicians don't realize, is that because the HIV medications have gotten so good, that the standard of care now is now something called U equals U. And if nobody knows what U equals U is, it's undetectable equals untransmissible. And the data is clear on this. It's a foundational element of HIV. If you take your medication and your viral load is undetectable, you can no longer transmit. That frees you up for sexual health. That frees you up for lack of shame. It frees people that want to have children up for being able to have a child and not being worried about transmitting HIV to that child, where a majority of the women that I now manage with OB are no longer having to have C-sections and AZT because their viral load is already undetectable. So the science shows that they can't transmit that to their child. They can't transmit it sexually. And so I think people need to realize that today, HIV is a chronic condition from a medical standpoint. We know how to manage it. We know how to get people through it. Medicine can't change culture. Medicine can't change fear. Medicine can't change stigma. But I think these conversations and these relationships are the ones that can start to break that down. I do believe the stigma is less today than it was in 1981.
Right. Absolutely.
I do believe we can find ways to lessen it even more going forward. And I think that has to be the work and the job that all of us continue to do.
And as long as we continue the conversation.
Absolutely.
And on that note, Dr. Losing, we appreciate your time.
Thank you so much.
And thank you for this illuminating conversation.
This was fun. We should do this again someday.
Thank you.
We would love to.
Thank you very much.
Well, Izzy, that was a really interesting conversation with Dr. Alozi, wasn't it?
He was fantastic and quite astounding as in his knowledge, but how the ease with which he shared his knowledge was really cool too.
I think ease is kind of the thing. I mean, not only is he smart and kind and professional, but on top of that, he's just kind of cool. He's like he's a nice person. He's got a really cool vibe. You can see why his patients love him because he's got such a great energy about him.
Absolutely. When I left, I was like, I want him to be my doctor. And then I remembered I love my doctor.
Yeah, me too. I was thinking that too. I think that anybody that meets him would probably want for him to become their doctor. But one of the things I wanted to ask you about was, what about how do you perceive the whole transition from where you started working in the AIDS crisis to where we are today. Tell me a little bit about that journey that you experienced personally.
Sure. Well, growing up in the 80s, that was when we first started hearing about HIV and AIDS. And I remember it being this ominous, weird, mysterious thing. And then by the time the 90s came around, I joined up in about the early to mid 80s. One of my very good friends from childhood, who you knew also, who you grew up with as well, had contracted AIDS, and I did not know how to respond or what to do.
That's interesting because I remember that time, and that's when for us, particularly here in El Paso, it was a big deal on the coasts. But that's when it really came home for me as well. That's interesting that event, and I know we're talking about Rodney, our old friend from high school, when he passed, that was a wake-up call. So that's interesting. So that started your journey a little bit, right?
Yes, it did. And inadvertently, I went to go try to understand what was happening to my friend and wound up in the smack dab in the middle of this crisis, this health crisis that was happening to gay men, and getting a good understanding of it and the inside view of it. And so coming from there and seeing, when I was working at the Southwest AIDS Committee, we had a end of life center at our facility because families were turning them away and they were left alone.
And impending death was that certain at those days. I mean, it was very kind of common that that's what you just expected was going to happen. Isn't that amazing that here we are now, where it is really just a controllable condition that, it doesn't mean that you're going to die of it. I mean, I knew that intellectually, but when I think of it through the perspective of what we've been through our generation has been through and what we've seen, it really is so reassuring. And in a way, I'm kind of glad that the younger generations don't even know what that was.
Oh, so am I. That having to watch your friends waste away and all of that was really, really tough. But, in talking with Dr. Alozzi, I had this lack of foreboding that I used to feel when I think about HIV and AIDS. And, I worked in the services for many years, and I worked as a volunteer and as a board member to help raise money for it. So I've watched it over decades. But after talking with Dr. Alozzi, I felt like, wow, this is a manageable condition now. This is what we had been aiming for ever so long ago. Yeah.
Absolutely. And with, of course, as he mentioned, with the ultimate eye being on an absolute cure. But I do want to say this, that thank God for people like Dr. Alozzi in our community, and that he is such an ally. He is so welcoming, and he is so non-judgmental, and you can almost talk to him about anything in great confidence. But I also want to point out that we got here through people like you, Izzy, through people that volunteered, that people that educated themselves, and people that were sitting next to dying patients. So it's been a journey for our community, for sure. It's been a journey for humanity. So for that, I'm very grateful.
Yeah, so am I. And to continue to have pioneers. When it was, that period in the 90s, there was this sense of crisis. There was this sense of urgency, and you had this activism. And then you started to see this kind of, a boredom with the topic, or, the community was...
Fatigue settles in, for sure. Yeah.
Mm-hmm. So to see this young doctor who is so bright and so learned and so inspiring in his knowledge, in his approach, the way that he spoke about his approach to treating patients was incredible. That's what made me think, I would love to have this man as my doctor.
Exactly.
Yeah.
And then on top of that, he does so much more than just HIV medicine. I mean, he does all sorts of things. So, if anybody is looking for a true ally in the medical community, I think Dr. Alozzi is it.
I think so too. Yeah. General practitioning, and also infectious diseases of all kinds, STDs and those kinds of things. He's well-rounded, and that's a very good practitioner to have, somebody who has that breadth of knowledge.
And that just adds to our vibrant community. So, for this episode, Agarra la onda, queers.
We'd love to hear from you. Email us at feedback@queeronda.com or visit our website and leave a comment. www.queeronda.com. That's www.queeronda.com.